Thank you, David. So I would like to discuss biomarkers and immunotherapy in GI cancer. I'm supposed to argue that it's a mess besides MSI high. Some disclosures. So the debate. We have the leading candidate, and then the runners-up, and of course the also-rans. T cell we know needs binding to the major histocompatibility complex, MHC, and when you have CD28 binding to these, that's called co-stimulation. But when you have CTLA-4 or PD-1 binding, that is an immune checkpoint, and that is what turns off the immune cells, here the T cell and the antigen-presenting cell, to reduce the amount of autoimmunity as a normal function. And similarly, PD-1 binds to PD-L1 and again can work between the APC or the tumor and reduce the T cell activation. So that isn't the only that is not the only checkpoint PD-1. Beside that, and you see many of the other drugs here that are already in the clinic, OX40 and 41BB, we have trials going on with those right now. GITR compound, another one, CTLA-4, there's ipilimumab and tremelimumab. So there are many combinations here of immune checkpoint inhibitors that can, or drugs that can interfere in this checkpoint activity. And that's kind of my simplified clinician point of view. If you move a little bit more into the immunological point of view, it gets a little more complicated because you have the tumor cell, you have the CD8 cytotoxic T cell, which is interacting with the dendritic cell, which interacts with other helper cells, tumor-associated macrophages or TAMs, and other cells, and these all, their interactions can all be mediated by PD-1 and PD-L1 and other such checkpoint inhibitors, so it gets to be a lot of parts of this, many moving parts in this very complex interaction that are susceptible to intervention here and the ability to disrupt the signaling pathway between immunity and the tumor cell or the tumor cell's inhibition of the normal immune system. So this is just a nice little graphic where the immune cell, only works for nivolumab. The other antibodies don't work like that. I just want you to know. What do we know about checkpoint inhibition in metastatic colorectal cancer? It doesn't work for regular colorectal cancer. But it seems to be reasonably effective. Again, there are no large trials that have yet shown this, but there are a number of small trials. There will be more data coming out at ASCO this year, including some that we've done with atezolizumab, showing that for patients with MSI high colorectal cancer, it is reasonably effective. And you've seen this data from Deng Li at Johns Hopkins that when you have mismatch repair deficient colon cancers, you have many more mutations per tumor. You won't see this on your report you get from Foundation One or anything. You have to do whole exome sequencing to get your 1,500 mutations. But they're there if you bother to look at all the introns and every place else that the genome is mutated. So if you, here this is the percent in tumor marker change and then also response. You've seen these data already on the anti-tumor response. So these are the best data that are out there showing that MSI high colorectal cancer does respond very well to an anti-PD-1 molecule. And that is also can be associated with the number of infiltrating T cells. But again, these associations are pretty weak. And it's particularly puzzling that colorectal cancer has one of the highest mutational burdens overall compared to other kinds of cancers, yet seems to have the less efficacy. So this is one reason why we haven't really hit the right biomarkers yet to be able to help us direct therapy for the majority of colorectal cancer. So one of the papers that I found most interesting at ASCO this year was this presentation by Giannakis from the Broad and Dana Farber working with Charlie Fuchs, looking at going back to the longitudinal health outcome studies to look at tumor burden. So what they do is look at the number of mutations, and then they use a computer algorithm to calculate the number of neoantigens. Those are kind of proteins on the cells that would actually induce some kind of immune response. And from that, they can show, looking back to the people who developed colorectal cancer from these prospective cohort studies, the Nurses' Health Study and the Health Professionals Follow-Up Study, they had like 170,000 people to pick out the few colon cancers, and they could then come up with about 1,000 patients who developed colon cancer. And what you see here is that there are very few that have these polymerase E mutations. Those are the hypermutated colon cancers. And they have the highest number of neoantigens and the highest number of mutations per megabyte of DNA, megabase of DNA, followed by the MSI patients. And then the MS stable patients are really pretty far down there and pretty close to zero. So this is one of the underlying mechanisms. And they also showed that this correlates with the number and type of infiltrating T cells that can help produce the immunity. So as you already heard from Frank, I mean, it's not just the number of mutations, it's the neoantigens, it's the infiltration by the T cells and how we can do that. But in this study, they showed that those who had high levels of neoantigens seemed to have better outcome in terms of survival. So that was very interesting. And these are not with treatment. This is just looking at these 1,000 patients of how they did based on their general outcome. So I think this is overall survival. It's a little bit better. So then we come to PD-1 expression, PD-L1 expression. There are a number of different methods for doing this. I think every company has its own secret sauce for what they call PD-1 positivity or PD-L1 positivity. These are data from the pembrolizumab gastric study. You can see patients who have no staining, positive staining, but really positive staining. So there's a wide range there. What does it mean? And here's some data from the Yale labs that we've looked at very different tumors, and we can see that there's a lot of heterogeneity. And in general, it doesn't seem to make a big difference on the responsive and non-responsive kinds of tumors, but we've classified them in those who have 4 kinds of classes, be they have PD-1 staining with or without T-cell infiltrates. So here's some actual clinical data from the gastric study. I think the name, Dr. Bang here at the bottom from the 2015 ASCO meeting, showed that there was no real correlation between survival and PD staining. The staining here, you can see that there's a lot of heterogeneity. This is from a lung cancer study suggesting that people had really high staining, but in general, you're talking about anything. If you try to get into a trial today, even the low-level staining you can get in with lung cancer. So, you know, this is an area that still needs to have a lot of work done. And from some of the patients we had at Yale where we looked at tumor biopsies after response, you can see here that there's a lot of, again, heterogeneity with necrosis, possible viable tumor cells, and some distorted immune cells. So it's, again, a lot of sampling errors here, a lot of questions how to do these immunohistochemical staining. I'm going to just skip this. In this study with atezolizumab, there is a difference if you have high-level staining, so a TC score of 3 or an IC score of 3 with a high-level staining compared to those with 0. So this did make a difference in outcome in a randomized phase 2 study of atezolizumab versus docetaxel. And those who had the high-level staining did seem to benefit more. Again, these are kind of multi-channel analyzers where we can now look at PD-L1 staining on the different T-cell subsets, the tumor cells, the CD3 cells, dendritic cells. So with the use of this kind of technology, we may be able to straighten some of these things out a little bit better. But I think it's far from being clinically applicable. And in the keynote 10 study, which was a lung cancer study, again, those who had high-level staining seemed to benefit more. And if you look across the PD-L1 positivity here, shown in the box, there does seem to be a little bit better activity for the high staining compared to the low staining. I'm going to just skip this stuff. So from there, then, as I said, people are moving on to combinations, and we've seen this already in melanoma, where the combination of an anti-PD-1 with an anti-CTLA-4 seems to have more activity. And this is not really predicted so much by the biomarkers, but in general, we see that the two checkpoint inhibitors together are more effective on this PFS in melanoma. And the staining does not really seem to help you out that much there. So there are many drugs that people are now using, trying to figure out how to put these together. There are more than we can do. There are probably even more studies here than the drug companies can fund, but it depends on what their next candidate molecules are, so it should be really interesting and a lot of fun. So in conclusion, the antibodies are actually validated for advanced disease in melanoma, non-small cell lung cancer, bladder cancer today, maybe MSI high colorectal cancer. We'll see when there are really some prospective trials. The toxicities are infrequent, but they can be clinically significant. There are patients who get rather substantial endocrinopathies, and that can be long-lasting and can be ongoing management issues. The biology is still quite murky. We don't know the value of the PD-1 staining or PD-L1 staining. So I would say that basically for colorectal cancer today, we believe that MSI high is really the group that's going to benefit the most for it, and other biomarkers I think are going to be on the back burner until we have better combinations and that we have better understanding of the underlying biology, if it's the ligands, if it's the immune infiltrating cells, if it's profiles of the immune infiltrating cells. These are all really good biologic leads, but none of them are ready for prime time yet.